Hello, I'm Dr. Kazal with CardioSource Video News, and we're delighted to have with us today Dr. Robert Epstein, the lead investigator of the MM-WES trial. The trial fundamentally addresses the question, can technology help us in administering warfarin more precisely and therefore reducing hospitalization? Dr. Epstein, tell us about the background of that trial.
Yes, well, we started thinking about the trial back in 2006. It was the year after the FDA had an advisory committee that unanimously decided that the label needed to be changed to incorporate genotyping. Also, we did our own database study in our population and found that over 20% of people were hospitalized within 6 months of starting warfarin. So putting those two together, as you mentioned, we thought maybe we should turn to the new science, genotyping, and see if we could make a difference in reducing that hospitalization. And that's really why we got started.
So tell us about the design of the trial.
Yes, the design is called a quasi-experiment, where we took a population of 23 employers and health plans. We looked at the new starts to warfarin and then tracked them for 6 months over time. A year later, we took the next batch of new starts and we genotyped them and watched them for 6 months over time, and we compared the two. And so it's considered a quasi-experiment because you're taking the same population before and after an intervention.
And what did you find?
We found roughly a 30% reduction in hospitalizations overall or for bleeding and thromboemboli within the 6-month time window. Interestingly, too, we found that the timing of the genotyping was important. The closer you could get it from that first dose of warfarin, the better the outcomes. But even if you got it a little later, you still did better than the control group.
So the physicians were advised to change therapy by, if they had the genotype, you would advise them to probably reduce the dose, check the iron more frequently. Is that the practical advice, or? Yes,
there are two genes that are responsible for predicting dose pretty well. It's been shown in dozens of studies over the last 10 years. One codes for cytochrome P452C9, which is the liver enzyme that metabolizes warfarin. So it tells you if you're an ultra-fast metabolizer, you need a higher dose than expected, or if you're a poor metabolizer, you need a lower one. And the other gene codes for vitamin K, VCORC1, which is the clotting factor. And of course, there's polymorphisms between us on that too. So taken together, the information says up the dose, lower the dose, or stay put with your 5 milligrams or wherever you started.
And that would be the type of information that would be very useful at the beginning.
It would be most useful at the beginning, absolutely. And actually, there was a new label put on the drug this year in 2010 by the FDA and the manufacturer, which gives a nice table for clinicians that says if you're this gene and this gene, this is the dose range that's right for you.
Excellent. One take-home message from this trial?
I think we're learning from this trial in general that genetics can really inform a dosing decision on drugs, and I think for other drugs it might even help us figure out which drugs to use.
Exactly. It will make us just more savvy and make better decisions.
That's what I'm hoping, and better outcomes for our patients too.
Very good. Dr. Epstein, thank you very much.
Thank you. It's my pleasure.